Hello everyone, I'm called Ishimwe Batitya. I'm a midwife student at University of Rwanda, and I'm very happy to be the part of this virtual education exchange program between Josa International University and University of Rwanda. So I have a topic here to share with you, and I hope it will be enjoyable and it will help us to gain some information about Rwanda. So I can share with you my topic. It's maternal and child health programs in Rwanda. So I can start by overview where the Rwanda is a rocket country in a Central East African with both mountainous terrain and plateaus. So the government of Rwanda prioritized reproductive, maternal, newborn, and child health throughout its policies and major health sectors reforms within a context of strong national ownership and health sector decentralization. Let us see in details those programs about maternal, newborn, and child health programs which are implemented in our country of Rwanda. So those programs include health facility program, vaccination preventable disease program, and the community health program. So we are going to see each program which include in each program here, what they do and how it is implemented in our country. So about health facility program, there is maternal and newborn health. It means from the conception to the childbirth, those events that have done there, they are included in this health facility program. The second one is child health. The next is family planning and gender-based violence death audit program, mentorship program, and monitoring and evaluation program. So those are duties that are done in this health facility. Let us move on, one which is vaccine preventable disease program. Here, there is a routine vaccination of the children from birth up to 15 months, where all children, all babies must be vaccinated for different diseases. And there is also vaccine and vaccine devices supply chain. The third program is called Community Health Program. This program includes maternal and child community health. It means the health of the mother and child there in our community, their everyday life. It includes also the nutrition service, adolescent sexual reproductive health, community-based provision of family planning, and supply chain of commodities. So those are the cares that will be done in these programs of our country. So let us see some graphs which can show us the data that we have according to each situation here in Rwanda about maternal, newborn, and child health care. So we can start by childhood vaccination. The percentage of children aged between 12 and 23 months with all basic vaccination. we can see here that the Rwanda Demographic Health Survey can tell us exactly the percentages in different years. For example, here in 2000, there is a percentage of 76% of childhood vaccination between those ages that we have mentioned above, 12 and 23 months. And also, we can look for this to 2005, where it increases by, no, it decreases. It was decreases by 75%, sorry. And between 2007 and 2008, it's 80%, while in 2010, it's 90%, and in the yellow color between 2014 and 2015, it's 93, and the high number is between 2019 to 2020, where it's 96%. So this graph can show us how these numbers, these percentages, were increased according to the years. So let us move next graph, where it can show us the trends in childhood mortality. This childhood it will be divided by 3 sections, where there is under 5 mortality, infant mortality, and neonatal mortality. So we are going to see the death per 1,000 live birth, where, for example, in 2000, according to the neonatal mortality, it was 45%, while for the infant mortality, in the same year, it was 107. And for the under 5 mortality, it was 96, yeah. So, according to the following years, 2005 up to 2020, it show us how this percentage were decreases according to these years, because when you compare 2000 and 2020, you can see how the neonatal mortality was reduced from 44 to 18, and the infant mortality reduced from 107 to 33, and the under 5-year mortality reduced from 196 to 45. So it's a very, very good thing about the childhood mortality ratio. So let's next slide and the next graph, which can tell us about the trends in the nutritional status of children, where percentage of children is under 5 years. We are going to see how the nutrition status were improved, and those problems of malnutrition were prevented according to different activities done by our country, done by our healthcare professionals. So according to these numbers, in 2000, the number of stunted children, it means too short for age, it comes from 48 and goes down to 33. It means it was decreased according to these numbers from 2000 to 2019 to 2020. So underweight, it means too thin for age. It was decreased from 20 in 2005. It was 18. 2010 it was 11, and now it's 8. While the wasted, it means too thin for 8. In 2000 it was 8. 2005 it was 5. 2010 it was 3. Between 2014 and 15 it was 2. And now up to 2020 it's 1%. So this also gave us the great image of how nutrition status have been improved in children under 5 years. So the reduction in mortality are associated with both improved coverage of effective intervention. For example, full child immunization coverage, it was increased from 69.8% to 90.1%. The second one is excessive breastfeeding rate, which was increased to 85%. There is also the prevention and treatment for the most important causes of child mortality, such as pneumonia, diarrhea, malaria, malnutrition, and HIV/AIDS. Those are the great things that our government have focused on in order to improve the child health care. So according to one of the most causes of child mortality here in Rwanda, there was some implementation that have done in order to overcome from this challenge. For example, to prevent this malaria, there was an implementation of insecticide treated nets to be given per house in order to prevent malaria. So here on this graph, we can see how the percentage was increased while they focused on this insecticide treated net in order to overcome this malaria disease. So from 2005 it was 15%, and 2007 up to 8 it was 56, and when we look for 2010 it was 82, and 2013 it was 83, and between 2014 and 2015 it was 81, while recently between 2019 and 2020 it's 66. So we can see how it comes from 15 and now we are like in a good percentage of 66, and we hope that this malaria will be continued to be prevented from children in order to prevent the other morbidity and mortality from this disease. So according to the fertility preferences on married women, here it's about the healthcare here in Rwanda. We can see how the percentage of married women aged between 15 and 49 by the desire of children, how it looks like. So from here in green, we can have the 10% of have another baby soon its percentage is 10%, and have another letter, it equals to 34%. And those who want no more or who are sterilized, their percentage is equal to 51%. And declared unvacant is 3%. So this graph shows how the percentage of married women is look like, about the desire of children, where only 10% of married women want to have a child soon, while those who want no more or who have the contraceptive method are 51%. Knew about the use of contraceptions in women here in Rwanda. The percentage of married women aged between 15 and 49, it means the age of reproduction. We are going to see their percentage according to the years. Here, we have the two types of blues. Blue, which looks like a sky, and the blue, which is dark one. We can see in 2000 where for any method for women it was 13%, while for any modern method, is 6%. And this can show us how it was increased up to 2019 to 2020, where for any method it increases up to 64%, while for any modern method is 58%. About unmet need for family planning, here it comes to show us where the women who are in productive age and who are fertile and who are probably got pregnant before, but they are not getting the way of doing family planning, the conception method, So their percentage of currently married women aged between 15 and 49, from 2000 it was 36%, while in 2005 it increases to 39%, and 2010 it was decreased up to 21, while between 2014 and 2015 it was 19, and then between 2019 and 2020 is 14. So this graph shows us how the percentage is still low. So the family planning, we need to put all forces here in order to be well improved about the family planning. So we are going to see the maternal health care, where the percent of live birth in the 5 years period before survey shows us how the antenatal care by skilled provider it looks like, and delivery in a health facility, and also delivery assistance by a skilled provider. Here from 2000, the antenatal care done by skilled provider for women for most recent birth, first it was 92%, and in 2005 it increases up to 94%, and from 2007 and 2008, it increases also up to 96%, while in 2010 it increases also and goes to 98%, and in 2014 and 2015 it took a peak up to 99%, and from 2019 to 2020 it goes low a little bit to 98%. So, but it is still in a good way. So for the delivery in a health facility, its percentage is the following. In 2020, it was 27%, while in 2005 it was 28%. And in 2007 to 2008 it was 45, and in 2010 it was 69%, and between 2014 and 2015 it was 91%, while between 2019 and 2020 it decreases up to 93%. So for the delivery assistant by a skilled provider, its percentage also increases according to the years, from 31% up to 94%. So about the antenatal care visit here in Rwanda, we can see how it looks like according to the region, from urban to rural, and then look for the total in general. Here from 2010 it was 40%, while for the urban area, it was 40%, while in 2014 to 2015 increased up to 44%, while in 2019 up to 2020 it goes to 49%. And for the rural area, in 2010 it was 35%, while in 2014 and 2015 it was 44%, and while in 2019 to 2020 it was 47%. So in general, the total ones in 2010 it was 35%. It means in general the area of rural and urban in general, while in 2014 to 2015 it was 44%. So the total now from 2019 to 2020 is 47%. So let us see the fertility trends, where birth per woman for the 3 years period before the survey. We can see how this graph showed us how from in 1992 up to 2020 the numbers decreases according to the years, from 6.2 up to 4.1. These fertility trends also decreased according to the data nowadays. And the fertility trends by the area of residence can show us how in the rural area is somehow different from the urban area here in Rwanda, where from in 1992 for the rural area it was 6.3, and in 2000 it was 5.9. In 2005 it was 6.3 also, and in 2020 it was 4.28, and in 2014 and 2015 it was 4.3, and in 2019 to 2020 it was 4.3. And for the urban one, its ratio from the 1992 it was 4.5. When you compare the rural area and the urban, you can see that in the rural area is where the number is high compared to the urban one, and continue to increase in 2020 and decrease a little bit in 2005 and equal to 4.9, and in 2010 it was 3.4, and 2014 and 2015 it was 3.6, and between 2019 to 2020 it was 3.4. Now let us see the trends in maternal mortality ratio here in Rwanda. We can see how this mortality rate get decreased according to the years. It means from 2000 it was 1071. It was too high. And in 2005 it decreased. Even in 2010 decreased also from 750 to 476. Even in 2014 and 2015, the survey showed how it continued to decrease up to 210. And also from 2019 to 2020, it's 203. And this can show us how the Rwanda have reached at least a good number compared in the previous years, where the number of deaths were too high. So we can see how Rwanda is doing too much in order to improve the health of the mother and children. So here we can see in nowadays the new schedule of antenatal care contact, how it looks like, how in nowadays is scheduled. So in the first trimester is where there is also the first contact. It means where the woman suspects that she's pregnant, or she has got the many symptoms and signs which can tell her that she's pregnant, and that signs and symptoms makes her to seek the medical care. So it means from that day the woman suspected pregnancy up to 12 weeks. While in the second trimester we have two contacts. It means the second one where comes when the pregnancy is about 20 weeks. And the following contact, which is the third, the mother will come when the pregnancy arrives at 26 weeks of gestation. And the third trimester, it includes the fourth contact, fifth, sixth, seventh, and eighth, where from 30 weeks up to 40 weeks, it means the woman must go to the healthcare and check how the pregnancy is in that days. It means at the fourth contact, it will be where the woman is at 30 weeks, and the 5th where the woman is at 4 weeks of gestation, on the 6th also at 36, and up to 8th contact, which is the last one, where the woman is at full-term pregnancy. So during provision of antenatal care, there are some services, some cares that we do here in Rwanda. For example, like history taking, when the woman comes to you and you see that she's pregnant, or she's suspecting the pregnancy, you have to do all the following. Firstly, the history taking, and to assess the mother and the fetus in the womb, do some labs tests in order to check well if she's pregnant or not, because there is sometimes that the mother can feel that she's pregnant while it is not, and she has maybe other complications, other condition which may cause the mother to feel like the way she is. So we have to check the labs also. There's also preventive measures, like to prevent the infections, to improve the hygiene, so that the pregnancy can continue in a good way. There are also management of common physiological symptoms, like the nausea, like vomiting, and other symptoms that the woman can mention during pregnancy, including those epimesis. Those can be managed here in antenatal care. So there is also the referrals in upper health settings in case of need. When you need further management, when there is some complication there, it's possible that mother can be referred to the next setting. So we have seen some challenges. There is some challenges that are shown even in the number, or how those problems are still there, but we can predict to correct them while we continue to improve the maternal and child health care here in Rwanda. So despite the notable improvement in Rwanda maternal, neonatal child health outcomes in post-genocide, maternal and newborn mortality and morbidity remain high here in Rwanda. So the key priority actions to accelerate the progress are to increase the number and improve the distribution of skilled birth attendants, especially strengthening the midwifery workforce. Here it means that we still have a challenge that here in Rwanda, midwives are still few, and the population to serve is high. So we need to strengthen the midwifery workforce in order to minimize or to reduce this morbidity and mortality that occurs for the mothers and children. The second one is to improve the quality of health services. Here we need to improve how we provide the services at our health facilities in order to improve the health for our population, for our people here in Rwanda. The next one is to strengthen the efforts in the areas of family planning, newborn health, and nutrition. So we have seen some stunted children where malnutrition is still there. So we can put the force there in order to reduce those challenges, in order to remove all those challenges and improve health in a good way. And also the family planning here can come and help us to improve the family, to improve our community, even our country. Because when family planning is in a process, we reduce some death that can occur when the mother is frequently given birth in the years which are following. And there is also to improve geographical access to the health facilities. Here we can improve the way of transport, the way our community, our people can come easily to seek our medical cares in easy way, so that we can prevent those home birth and those complications which can occur for the people while they are staying home. There is also intensify efforts in mother and child malnutrition. The other one is greater focus on newborn health. From the birth up to 1 month, we can take care of that newborn, that baby who is coming in a new life here, and we can prevent for them some infection, some diseases that can occur in that. So we have seen many about maternal, child and neonatal health in Rwanda. So as conclusion, by ending preventable death of women, newborn and children and also the adolescent, we can significantly improve their health and well-being. So this means that we can prevent all those complications which can occur in order to improve their health and well-being. So it's up to us, the healthcare professionals, to deal with all those complications of pregnancy and childbirth and unwanted pregnancy, and also lack of access to or use quality healthcare services and life-saving commodities, as they are among causes of preventable diseases. So this content is what I have prepared for you. I think we have get some knowledge, some information about maternal, neonatal and child healthcare programs here in Rwanda, and we hope to improve all these activities in order to improve also the health of those mothers, those children, in order to live well. So thank you very much. Thank you for your kind attention, and thanks for your concern. Be blessed.